Hi.
Hi, is it okay to come in?
Yes.
Hi, I'm Rosemary Gillespie. I'm just going to get I'm a nursing instructor. I'm just going to get your vital signs. Is that all right
Sure.
with you?
Sure.
Okay. Do you mind if I take my mask off?
No, that would be
Okay.
fine. I know it's hard to talk with the mask on.
Great. Can you just tell me your name and date of birth?
Yes, my name is Biji Georgy and my birthday is April 7, 1976.
Great. And I'm just going to put your bed up just so I'm not stooping.
Yep.
Okay, first thing I'm going to get is your temperature. So normal temperature is 90 for an adult, 96.4 to 100. For children or for an infant, it's 98.7 to 100.5. Although with newborn infants, we really worry about their temperature. If their temperature drops below 97.7, they can go into respiratory difficulty, they can drop their blood sugar. It's just a whole chain of effects. So definitely want to keep our babies warm. Before I take your temperature, any nausea or vomiting?
Nothing.
Okay. I don't want to be sticking anything in anyone's mouth that had recent oral surgery or has any infections in the mouth. Or if you've recently had anything hot or cold to drink?
No.
No? Okay. Chewing gum?
No.
Smoking?
No.
Okay, good. So I'm going to get an oral temperature on her. Okay. Thermometer is right here. Okay, and I'm just going to pull this out, wait for it to beep. And it beeped. So I'm making sure that it is an oral. You can change it to axillary or rectal on this button here. You're going to put a cover on it, and I'm just going to ask thank you to pull your mask down.
Yep.
Okay, and if you could just put that under your tongue and seal your lips around it. And you want to make sure that they can close their mouth. So if you have a patient that has dementia, they're unable to close their mouth, maybe you shouldn't be taking an oral temperature on them. Okay, and her temperature is 98.9, nice and normal.
Thank you.
So I'm just going to put this in the trash. Okay. I'm just going to get your radial pulse here, okay? So when I'm palpating the radial pulse, I'm palpating how strong it feels. Does it feel like a normal pulse? Does it feel weak or thready? Does it feel bounding? I'm also palpating the rhythm. Does it feel like a regular rhythm? Are you feeling any skip beats or extra beats? So, and you're going to count the pulse for 30 seconds and times it by 2. Great. Your pulse is 72. Okay. The other thing, I'm also now going to get respirations. And when I am obtaining respirations, there's lots of things I'm looking at. I'm looking at their color, okay, because if they're not getting good oxygenation, their color is going to change. I'm looking at their facial expression. If someone cannot breathe properly or is short of breath, they're going to be a little panicked, okay, so they're going to see that. I'm also looking at the symmetry of the rise and fall of their chest when they breathe in. There should be equal expansion. And the diameter of the chest we're also looking for. So when they breathe in, we're looking for use. So adults are thoracic breathers. So this is normal, seeing the rise and fall of her chest, okay, and it's moving symmetrically. I want to also assess if they're having any retractions, and retractions are when they breathe in. Do you see any of the skin getting pulled in into those intercostal spaces? That's usually signifying trouble. If they're using their abdominal muscles to breathe, if they're using accessory muscles to breathe, then that's usually indicating that they're having some kind of issue. So I'm just going to pretend I'm also still taking her pulse, and I'm going to watch her breathe. And the reason I do that is if people know you're watching their respirations, sometimes they'll change their respirations. So again, I'm going to count for 30 seconds and times that by 2. Anytime you get an abnormal vital sign, you do it for a whole minute, and you recheck it. Okay, so I'm just going to watch her breathe. Perfect. And her respirations are 14. So normal respirations for an adult are 12 to 20. And again, you're looking for symmetry and equal chest expansion. You do not want to see retractions. You do not want to see use of accessory muscles. They're all telling us that something is wrong in terms of the patient receiving enough oxygen in their blood. Okay, so we would just want to look at that. The next thing I'm going to do is take her blood pressure. When you're taking blood pressures, you want to make sure that you put your stethoscope in correctly. So if you can see the stethoscope, these ear prongs are pointing outward. That is the way you put it in your ear. You do not put it in this way with the ear prongs pointing that way. You want them pointing outward. Okay, so they're going to go like this. You also have a diaphragm and a bell on your stethoscope. For blood pressures, you want to use your diaphragm, and you just want to gently tap. And if you hear it, it's on the right side. When you tap, if you do not hear it, you need to turn the stethoscope so that you can. Okay? So when we're doing blood pressures, we want to think about things that can affect blood pressures. Medications can affect blood pressure. Activity level can affect blood pressure. Also, pain level is another thing that can affect blood pressure. Your systolic. So blood pressure is measuring the force of pressure that blood puts against the artery walls. So the systolic blood pressure, it's written in a fraction, is your top number. And that is when the ventricles are contracting, and that's going to be your higher number. And the diastolic is when the ventricles are relaxing and filling out with blood. So that's going to be your lower number. So you're going to have your systolic and your diastolic pressure. Anything over 140 over 90, we consider hypertension. But people can get what we call the white coat syndrome. So they are anxious because they're at the doctor, so their blood pressure goes up. So if you get an initial reading that's high, you're going to let them sit for 10 minutes or so and then retake it. Okay. Other reasons that it could be high, they could be pain. So anxiety is a huge one, pain is another one, or they may just have hypertension. So we're going to check their blood pressure. We're going to get our cuff here. Okay. So this is a sphygmometer, and it measures in millimeters of mercury. Okay. This is your cuff. Very important that your cuff is the correct size. If it's too tight, you're going to get a higher reading. If it's too loose, you're going to get a lower reading. It's very important that you guys know what normal vital signs are. If they are abnormal, that you recheck them and you recheck your equipment, that it's functioning properly. If they're abnormal and you've rechecked your equipment, you've rechecked your vital signs, you need to figure out what's causing these abnormal vital signs and what your nursing interventions are. They always need to be reported abnormal. On your cuff here, you have an artery line here, okay? And so I'm going to palpate right here for the brachial. I'm feeling it nice and strong. And that's where this arrow is going, right where I'm feeling that. Okay, so I'm going to place the cuff on her arm. I'll wrap it around with the Velcro. Okay, is that nice and comfortable?
Yes.
You want it nice and snug, but you should be able to get a fingertip in there. Okay? We did the two-step method of blood pressure recording, and the two-step method will just guide you in how much to inflate this cuff. You don't want to inflate it too much because it does start to become uncomfortable for the patient. So basically what I'm going to do is you're going to have her level of the heart, okay? When you're taking blood pressure, legs shouldn't be crossed. All these things can affect blood pressure. So I'm just going to gently rest her arm here and palpate her radial pulse. I'm not getting a rate, I'm just palpating it, so. Okay, I feel it. So now I'm going to close the valve on this, okay, to the right to close it. And I'm going to inflate this till I no longer feel this radial pulse. So I'm going to watch this as I'm inflating this and feeling the pulse. Okay, and the last time I felt it was around 132. So the two-step method, I'm going to release this valve so that her arm can relax and fill with blood again. The two-step method, you're going to palpate to the radial pulse. You're going to inflate the cuff until you cannot feel that pulse anymore, and you're going to note that number. And for Miss Georgie, it was 132. So then I'm going to add 30 millimeters of mercury to that 132, and I'm going to get 162. And that's how high I'm going to inflate the cuff when I'm listening to her blood pressure. So we're going to, in between, we're going to wait a minute, okay, let that blood refuse, and then I'm going to pump it up to 162. So I just want to feel here. Okay. When I am pumping this up and when I am holding the stethoscope here, I want to minimize movement of these cords, my fingers, all these things, because it can give you artifact that you're going to hear. I'm going to inflate it to 162. And then I'm just going to slowly release the valve. First loud sound you hear is your systolic. And then the last sound that you hear is your diastolic. So her pressure was 110/62. Okay, and that's a nice normal pressure. So there, I'm going to put your rail back up because I'm done. All right, the only other thing I have to do is assess your pulse oximetry, and 95 to 100 is normal. So this is just going to go around your finger. You could just place your finger in, okay, and that's just going to measure your oxygen saturation. Sure. And they are 97. Perfect. Okay. Are you in any pain right now?
No.
Okay, on a scale of 1 to 10, 0 being no pain at all, 10 being your worst pain ever, are you experiencing any pain?
0 pain.
0 pain. I like that. Okay, great.
Can I come in?
Sure.
My name is Biji. I'm one of the nursing instructor, and I was thinking to do a physical assessment on you.
Sure.
Are you okay with it?
Okay.
I'm going to take my mask off if that's okay with you.
Sure.
May have to put this back again. So can you tell me your name and birthday?
Sure. My name's Rosemary Gillespie, and I was born 3/15/70.
Okay, I just want to make sure you have the right information right here. Yes, you are the right patient. I'm going to bring your bed up, so this way I'll have the perfect working height. Okay. I think this bed is working, yes. I always want to make sure you save your back if you are going to be nursing for long. I think that's good for me. Alright, so the most important thing for students to do before they do a physical assessment is to review a patient's chart. Make sure you review a patient's chart. Make sure you know your patient's medical diagnosis, and also to know patient's history, including a little bit of medical history and past medical history, past medical surgical history. That helps you to actually kind of focus on your assessment where you have to focus. So that being said, the next thing you have to do is making sure your equipments are there and whether they are in working condition. So for doing a physical assessment, the equipment you need is actually a pen light, and you want to make sure my pen light is in working condition, and you want to make sure you have a couple of alcohol swabs and your stethoscope. So I have my stethoscope and everything ready to go. So let's do the system-wise assessment. You will see me actually using this paper because I'm just going to follow exactly the physical assessment form you have in your hand. But once you get used to doing this physical assessment, once you are an experienced nurse, you are not definitely following the steps you have in this form. But I'm going to follow the steps what we have here. So the first system I'm going to be assessing is the neurological assessment, neuro system. So when you assess your patient's neurological assessment or neuro system, we are assessing the level of consciousness. We are assessing the some of the sensory and motor functions. So with that being said, I'm going to be asking, can you tell me your name?
Rosemary Gillespie.
Do you know where you are?
I am at Marple Sim Lab.
And do you know what time of the day is it?
It is
No, 11:30, I guess.
Okay,
I know.
good. You
Yeah.
are right. It's about 11:30. So since your patient said all those three things right, the name, the place where they are, and the time, you can actually document it as alert oriented times 3 or AO times 3. Then let's move on to the next step. So on the next step, it says check your patient's forgetfulness or confused or whether they are comatose. I'm not going to explain all of those things right now, but you have to know those things because when you assess your patient's neural status, you really need to know where they are. But for Miss Rosemary, I definitely know we just did it and she doesn't belong to any of those agitation or confused or comatose status. So we are good with her level of consciousness. Next step is actually to see how was her verbal stimulus. So some patients, when you talk to them, they won't respond to the verbal stimuli. You may have to actually pinch them. So for Rosemary, since I actually spoke to her and she answered appropriately, her verbal stimuli is intact, no problems with it. Next thing we're going to be checking is the tactile stimuli. So for tactile stimuli, it's the sensation. So what I'm going to do, I'm going to be asking Miss Rosemary to feel my touch. So I'm going to be asking. Most of the time when I feel the patient to identify the sensation, I will be touching a couple of places on their upper and lower body. So do you feel me touching?
Yep.
Do you feel me touching here?
Yep.
And you wanted to make sure anything you do on one side, you have to do on the other side too. That's extremely important for you to understand. And I also wanted to make sure she's able to feel me touching on her lower part of the body. So I'm just going to uncover this for a second. So I will be checking, do you feel me touching here?
Mm-hmm.
I'm sorry, my hands are probably cold.
Mm-hmm.
How about that?
Yep.
Do you feel me pinching?
Yep.
How about here?
Yep.
Good. So she's able to actually feel me touching or pinching. That's a good sign. The next thing on the neuro assessment, you have to make sure their speech is actually intact. There is no signs of slurred speech. And I will be asking Miss Rosemary to open her mouth. And I can put the mask on while you are doing that. Can you open your mouth and stick your tongue straight out? So what I'm looking here is I'm looking whether the tongue is in midline position, and also I'm checking at the top of the tongue to see if there is any white patches. Sometimes they may have that white patches due to the medications they are taking. Thank you. And if they have their tongue in midline position, that indicates they have no swallowing difficulty. You are good to feed them. There are no indications for aspiration. So that's something you always have to pay attention to. And also some of the other terms you have in your neuro assessment is whether they have any aphasia, dysphasia, or voice hoarseness, epistaxis. You need to understand these things and apply as needed. So the next thing is actually to check the facial droopness. So to check the facial droopness, we are checking the cranial nerve functioning, if they have any neurological impairment for their cranial nerve. So what I'm going to do, I'm going to be asking Rosemary to give me a smile after taking your mask off. Can you give me a good smile? Beautiful smile. So if you see her both lips are going up equally, the both sides of the mouth is going equally up, which means there is no facial droop. But if one of the sides are not going up properly, which means she has actually a droop in that side. It could be a right or left droop. And you will see this on your patients who has accidents or stroke. I'm going to be asking you a few questions. Do you have any history of headache?
No.
How about feeling dizzy or lightheaded?
Nope.
Good, that's good to know. So you always wanted to make sure they are safe to walk. That's the reason why you are checking whether they have any dizzy episodes or they feel lightheaded, because that could be a problem that you have to find out and take interventions before you take your patient for a walk. The next thing what we are going to be asking is this. We will be asking about your visual and hearing functioning. So for vision, I'm going to be asking you Are you using any eyeglasses for reading or for seeing in distance?
I use reading glasses.
Okay, and do you have them all the time?
Yeah.
Good. And how about any hearing aids?
What? No.
Okay, so that's great. She's nice and she's funny, and she said, no, I don't have any hearing aids. Good to know. So I'm going to be still checking my patient's hearing by asking her to say something back what I am going to ask her. If I say something to you, if I whisper something, can you say that back to me?
99.
Good job. So she can hear. Her hearing is intact. Then if you look at your sheet, you can see you have to also ask them whether they have any other hearing impairment. So as I said, this all goes along with your patient's condition. And in your neuro assessment, we will be checking the PEARL. What is PEARL? PEARL is actually checking the pupil, the patient's pupil. So PEARL stands for pupil equal, round, and reacting to light. So pupil is actually round in shape, equal in size, reacting to light. Because when you put the pen light, when you shine the light in your patient's eye, if the pupil is constricting, it means their pupil is able to constrict as they wanted to see things. So I'm going to check that. Do you mind putting your mask on? Okay, so I will be shining the light from the side to the pupil just for a few seconds. And I will do the same thing on the other side just for a few seconds. And as the light shines the pupil, you will see the pupil is constricting or getting smaller. What's the normal pupil size? So the normal pupil size, I don't have this on this pen light, but I have another one. You can actually get one of these pen light. This has the pupil gauge, and the normal pupil size is actually between 3 to 5. So when you are actually looking at your patient's pupil size, if they belong to that 3 to 5 range, your patient's pupil size is normal. So we are good there. So your pupil is perfectly fine. It's reacting. And the next thing I wanted to ask is this: do you have any sensation of tingling or numbness in your upper or lower extremities?
No.
No. With that being said, I'm going to be checking your strength on your upper and lower extremities. So before I check the strength on your upper and lower extremities, I'm going to be asking, just for safety reasons, do you have any limitations in movement or any restrictions in upper and lower extremity?
No.
Good, that's good to know. So you are going to simply follow my instructions, and then that will be how you will be checking the strength of your body. So what I'm going to ask you is this: can you actually bring your both arms up? Good job. And I'm going to push down here. When I push down, you're going to resist.
Oh, okay.
Good job. I'm going to push up. You will be resisting. Good job. And also, you wanted to make sure you actually give 2 of your fingers to have them grab. We are actually checking the strength. So can you squeeze as fast as hard as you can? Good job. You're strong. And you wanted to check the same thing on the lower extremity. So I'm going to be taking the cover off, and I promise I can actually put them back. So what I'm going to do, my hands are cold. So I will be pushing your feet up. You don't let me push. Good job. And I will be pulling your feet down. Good job. So she has equal strength. So her strength is good. So that is actually our neuro assessment. So the next system we are checking is your cardiovascular. So students, remember, cardiovascular is your perfusion. You wanted to understand, or you wanted to identify, how is their perfusion? Are they able to perfuse enough to their body? So the first thing is actually to understand how is Miss Rosemary's blood pressure. So I checked Rosemary's blood pressure an hour ago during my vital signs, and her blood pressure is actually 130/70 millimeters of mercury. So what I'm looking when I'm looking my cardiovascular assessment for the physical assessment, her blood pressure is stable enough for her. I'm not going to be looking for the book normal numbers. If that's something stable for your patient's blood pressure is good. So 130/70 millimeters of mercury is a good blood pressure. And then I'm going to be listening to your heart. So listening to your heart is going to be an apical pulse. So when you listen to the heart with apical, to find out the apical pulse, you wanted to make sure you have a stethoscope, and I would recommend you to actually clean the stethoscope before you actually use it for your patient. So I'm going to clean the diaphragm of the stethoscope. It's going to dry, and I want to make sure I put the ear tip in the right way, and I want to make sure this is in working condition. So I have all that checked. So I'm going to be actually explaining what are the things you're going to be paying attention when you are actually listening to that apical pulse. You will be taking, or you will be counting the apical rate for a full 1 minute. You have to make sure you listen to that rhythm, the lubbed up sound, lubbed up, lubbed up, lubbed up. Is it regular or irregular? If it's irregular, then it's an arrhythmia. You wanted to make sure you pay attention to those things. Then you have to pay attention and find out, am I hearing any extra sound or any swishing sound before that lubbed up or right after the lubbed up? I have to pay attention. Those are my heart murmurs. So these are the three things. So we will be listening, we will be paying attention or counting the rate. We will be paying attention to the regularity, the rhythm is regular or irregular. Then also we will be paying attention if there is any extra sound or abnormal sounds that I'm hearing when I'm listening. So to listen your apical pulse, you have to have your landmark knowing. So the landmark for the apical pulse is actually the mid-clavicular, left side mid-clavicular 5th intercostal space. So since my stethoscope is ready to go, I'm going to place that on my patient. So this is what I would say. I'm going to give her the privacy, and I'm going to find my landmark. So I'm going to just kind of approximately, you can just relax.
Okay.
I will give you your privacy. I'm going to mid-clavicular 5th intercostal space. And as a student, you have to understand, when you are listening to a female patient with, large breast, to get that apical pulse, you may have to actually displace their breast. So when you displace the breast, you have to displace them by the back of your hand. Don't push it with your palmar part. So pay attention to those things. So I'm going to do that right now. It's normal. So I'll listen for a full 1 minute. If the rhythm was normal, the rate was normal, and I didn't hear any extra sound in between the lubbed up. So it's good. Do you have any chest pain?
Nope.
Do you feel short of breath, or do you have difficulty in breathing?
No.
It may be in sitting position, walking position, or in laying position. None of that. That's good. So we wanted to make sure they have no trouble with breathing. That's an impairment in perfusion. Always think as a nurse when you ask these questions and put that to your patient. That's the reason why we said it is important to know their past medical history, past surgical history. So when you ask these questions, you can ask those questions that's very specific to that patient's condition. All the questions out here are not going to be applicable for your patient, but you need to know what are those specific questions. How you will know that with practice, with knowing what goes under where. So the next thing I have to check under the cardiovascular system is checking the capillary refill. So to check the capillary refill, we have to actually check the patient's nail beds, or the fingernail and also the toenail. So you can actually use a couple of fingers. So I'm going to ask you, I'm going to be, see with my index finger and my thumb finger, I'm going to be pushing down the fingernail and holding it there for a few seconds. Can you see it? And you can see within 3 seconds the color came back. If somebody has nail polish, this is what you can do. You can actually just do the same thing over here. Just press down and let go. In 3 seconds the color is back. So which means she has good capillary refill within 3 seconds. That's what we want. The same thing with the toenail. We wanted to do the same thing. So I will be doing that on your close right now. So same thing, since she has nail polish, I'm going to be checking that in here, see? Release. The color is back. So the good capillary refill. So good that you have good circulation. All right, so checking the patient's temperature, whether it's warm, cold, that also has to do with perfusion. You know, if they perfuse enough blood to your body, the body temperature should be normal. So how would I check that? I'm going to use the back of my hand, and I'm going to be checking the skin in multiple places. Yeah, it's normal temperature. It's normal temperature. And I would do the same thing. I would take my sheet off and I would do the same thing on the lower extremity too. So you have to know those abnormal the abnormal conditions with the skin, like, you know, the temperature is cold or clammy or diaphoretic. That tells something to you. There's impairment with the perfusion. That's what you are understanding. So now let's move on to the pitting edema. So when you actually hear the word pitting edema, as a nurse, you have to understand if there is an edema in your patient's body, there is an impairment in the circulation. So pitting edema could be anywhere from 1 to 4. That's the grade we usually use. Pitting edema is actually when we actually push your index finger into the patient's edema site. If they have any indentation or pit, as you push down, it will be showing up there, and depends on the depth of that pit, you will be actually grading it. It's +1 or +2, +3 or +4. So I'm going to show you that right now. So what I do is this way. If I am looking at the pitting edema on the ankle, I will be taking my index finger and I will push down and hold it for 10 to 15 seconds. 15, release. If they have an indentation or pit, that means they have pitting edema, and I have to document that because that could be a problem with the circulation, or it could be congestive heart failure. So it's important to know and understand how to grade and do the pitting edema. Then let's move on to the palpation of pulses. When you as a nurse palpate the pulses, you need to know different sites for palpating pulses. So when you palpate the pulse, we will be palpating the pulse on bilateral radial, bilateral popliteal, that's the one right under the knees, and then you will be palpating the pulse, if you needed to, on the posterior tibial and the dorsalis pedis. But in our regular nursing practice, the most two important pulses that we are palpating and grading are only the radial and the dorsalis pedis. So what I'm going to do, I'm going to show you how to actually find a dorsalis pedis and how to grade it. When you talk about grading a pulse, it's actually grades from 1 to 3. We really don't have to grade with numbers. We really have to identify the quality of the pulse. Is it strong? Is it weak? Or absent? If it's strong, we are good. The +2 would be normal. That's strong. If it's weak, then it's a problem. There is a decreased perfusion. It's absent, we are in trouble. So we may have to actually grab a Doppler and probably check for that pulse and make sure it's palpable or not palpable. If not, we have to document and take further steps. So for dorsalis pedis, I usually do them at the same time, you know, the highest spot on your dorsal part of the foot. And I can feel that right here, bilateral. So, but you always wanted to make sure you compare the sides. You want to make sure you know how is the right versus the left. The next thing we are going to be checking is this. We're going to be asking your patient if they are on any hemodialysis. You may have this information from your nursing shift report, but if your patient is on hemodialysis, you have to assess their dialysis access. They may have an AV fistula or an AV graft for their hemodialysis. So nurses have to listen to that dialysis access, and also we have to feel to make sure that access is in working condition. So when you talk about the dialysis access, we will be checking the bruit and the thrill. So how do I check the bruit? So for example, if Rosemary has one of those, I will be auscultating the bruit with my stethoscope. So I will take the diaphragm of my stethoscope, I will warm that up, put that on top of the dialysis access, and I can really hear that swishing sound, which means that's a good access. It's patent. And after I'm done with auscultation, what I would do, I will palpate. What I'm palpating, when I palpate with my fingers on the top of dialysis, on top of that dialysis access, I can actually feel the pulsation, which means you're feeling the thrill. That means your dialysis access is patent. And the next thing I'm going to ask is this, Miss Rosemary, do you have any pacemaker or an internal cardiac defibrillator?
No.
So this is something as a student nurse you may have to actually ask. If they have an internal device, you have to make sure you actually document that, at least in your nursing documentation. We are not checking anything, but we have to have that knowledge. And if there are any other findings with the cardiovascular system that goes along with that particular patient's condition, you have to ask and document. So the next system we will be looking is the respiratory system. So in respiratory system, we will be inspecting and then we will be auscultating. So when you inspect, you are inspecting the patient's chest wall. So I will be coming to Miss Rosemary and I'm looking, how is her chest wall? What's the symmetry of that chest wall? What's the configuration? Is she using any accessory muscles to breathe? So these are the things you are looking or inspecting. If there is no indications of any of those, you still have to understand what you have in your physical form, because you may have a patient with a history of COPD and they may have a barrel chest. So you need to know what is barrel chest, what is that has to do with the COPD. And then what I'm going to do, I'm going to start listening or auscultating my patient's lung sounds. So when you auscultate your patient's lung sounds, you can actually auscultate anteriorly, the front, posteriorly, the back, and you won't really auscultate all the time laterally, but I would say you also need to know how to actually auscultate laterally. That's going to be under the axillary. The reason why, because if you have a patient who is heavy, who cannot move, when you are doing your morning assessment, you cannot get to that patient's posterior or back side. You can only listen to the anterior, the front, and then you can actually listen to the mid-axillary line a couple of places to listen to that lateral lung sounds for the posterior part. So I'm going to show that to you. And Ms. Rosemary, this is what you're going to do. You're going to be asked to take a couple of nice deep breaths, but if you have any difficulty, let me know, and I can stop anytime when you have a trouble breathing. Okay. So I'll be listening for a full breath, inspiration and expiration, because when I'm listening, I'm looking for those adventitious lungs, because the adventitious lung sounds are actually wheezing, bronchi, crackles. So you have to listen and understand, am I listening them during inspiration or am I listening them during expiration? That has something to do with their medical condition, and you will be documenting that I heard expiratory wheezing. So that's why it's important for you to actually pay attention, listen, and listen for the full breath. And don't expect to start listen as soon as you place the stethoscope or the diaphragm of the stethoscope on patient's chest. So you will see me doing it. Okay. Can you come forward a little bit? Good job. Nice deep breath. See, I'm going to go above the clavicle. 1. Good job. Another side. Good job. Good job. That would be the second intercostal space. Oh, another one. And then I will be doing one more down here. Good. So I'm listening and paying attention for that full breath sounds. Now what I'm going to do, I'm going to show you where I can actually listen to the posterior and lateral from the other side. So I will come around. So make sure when you listen to the posterior lung sounds the same way, you have to start listening above the scapula. So this area right here on both sides. And you have to understand you have your scapulas in both sides. So you wanted to listen actually in the middle, not on the bony prominence. And when you listen, you have to go outward, like an outward C. So I'm going to show you how to do that. Can you take a nice deep breath? Good job. Good. Nice deep breath. Good. Good. Nice deep breath. Good. Nice deep breath. Good. Nice deep breath. Good. Nice deep breath. Good. So I was going and an outward C starting above the scapula. So you have to pay attention, take your time, and make sure your patient is comfortable too. Now I'm going to show you how to listen to the lateral lung sounds if we couldn't get to the posterior side. So you can go under your patient's underarms, axillary, mid-axillary line, and listen. Nice deep breath. Good. So I would be using this only for the patients who cannot move. And you saw me actually listening over the gown. Never ever do that. You wanted to make sure the diaphragm of your stethoscope touches patient's skin. Another tip is this: when you listen to lung sound or any sounds, anything you auscultate, if you can bend your neck down, you can pay attention more clearly. You can concentrate better. You can occlude the surrounding noises. So you may see a lot of physicians when they listen to the lung sounds, they are looking at the patient's bed. So those are some of the tips to actually listen clearly. And you may be asking, when do I use the bell or when I use the diaphragm of my stethoscope? So most of the time the diaphragm of the stethoscope is using for listening the high-pitched sounds. So that's why you will hear us listening to these lung sounds, heart sounds using the diaphragm. And the bell of the stethoscope is usually for low-pitched sound, which we don't usually do a lot. I just wanted to give you that heads up. So we just finished with the inspection and palpation, and Ms. Rosemary, I didn't hear any adventitious lung sounds. Your lung sounds are good. They are normal. So when you document, make sure you document actually 3 sides on the right upper lobe, right middle lobe, right lower lobe, and you document on the left upper lobe, left lower lobe. Do not ever forget. Even if you hear normal lung sounds, you still have to check off that lung sounds on the right upper lobe. So the next thing is actually to ask the patient more persistent to the respiratory system about their breathing. Do you have any difficulty in breathing? Do you have any problem breathing when you're in a laying position?
No.
Good, that's good to know. So you have to pay attention to all the other choices you have in your sheet and make sure you actually ask that or apply that and document, depends on your patient's condition. And I'm going to be asking you about your coughing. Do you have any cough recently?
No.
Okay, so that's something you have to pay attention. You ask your patient whether they have any recent cough or are they coughing. If they say they have cough, you have to ask them whether the cough is actually productive or non-productive. What does that mean? In productive cough, they will have phlegm or sputum. If you have phlegm, then you may have to actually look at the consistency and the color of that sputum. But if they say, oh, I don't bring anything out, which means you are only documenting that as a non-productive cough because it's a dry cough. Sometimes with ALC inhibitors, patients may get some medications, they may get that dry cough, and we don't do any interventions for those. And the other thing, you may have to look at the patient's surroundings, and you can even ask patient, Miss Rosemary, do you take any supplemental oxygen at home? I don't see anything here.
No.
Okay, so you always want to make sure they are on any supplemental oxygen. Sometimes your patients may have sleep apnea, or they may be using CPAP at home. If they have any supplemental oxygen, you have to document what's the amount they are taking and what's the device they are taking. If they are taking supplemental oxygen like a nasal cannula continuously over 2 liters for over 24 hours, you may have to think about giving some humidified oxygen. So think those things and apply those things, depends on your patient's condition. And then we will be looking and asking, are you using any incentive spirometer?
No.
No, okay. So you wanted to make sure, are they using any extra devices for lung expansion, any coughing or deep breathing exercises? Are they using any breathing treatments? If they are using the breathing treatment, sometimes their heart rate can go high. So you have to pay attention and notice those things as a nurse to understand. And if there are any other lung abnormal findings, you may have to document that too. So the next system we are going to be assessing is your gastrointestinal or your stomach. So when you are assessing your patient's gastrointestine, you wanted to make sure you are actually following the pattern of doing that assessment properly. So we have to follow the pattern of inspection going first, inspection, then you will be actually auscultating, and after auscultation you will be percussing, and lastly you will palpate. Otherwise the findings can be changed with your influence of palpating in the beginning. So in inspection, what we are going to do is this. We will be looking at the stomach. We will be looking at the shape of the stomach. Is there any surgical marks? Is there any abnormality? That's what we are looking for. So after inspection, I'm going to be asking a few questions. Do you have any special needs with your diet?
No.
So you are taking a normal diet, regular
Yes.
diet. And you also have to ask to your patients in detail if they are on clear liquids. Or what kind of liquid diet they are taking, because not all the patients can be on liquid diet and take thick liquid. So as student or as nurses, you wanted to make sure I pay attention to those liquid diet. And some patients may be on renal diet, on cardiac diet, or sodium restricted diet. You as a nurse have to know that and ask your patient, are they following that at home? That's a patient education moment. And then we will be asking, how is your appetite? Are you eating fair, good?
Yeah, I eat all my meals.
So that's important, because they need to have proper nutrition for their body's well-being. So you will be asking that. Then I'm going to do my auscultation. So when you auscultate, we will be auscultating the vowel sounds. You will hear that gargles or clicking sound or clicks. And when you auscultate, you always have to auscultate the pattern I'm going to say, and you have to memorize it. You will start off with auscultating at the right lower quadrant, then to the right upper quadrant, and then you will move to the left upper quadrant, and then lastly to the left lower quadrant. And when you auscultate, you wanted to make sure I'm listening to the vowel sounds. The normal vowel sounds is 5 to 34 per minute, but you have to understand, do they have hypoactive vowel sounds, hyperactive vowel sounds, or absent vowel sounds? So if it's anything below that 5 per minute would be hypo, anything above that 30 or 34 would be hyper. And the absent vowel sounds, you cannot just document that, you have to actually listen for full 5 minutes, in some textbook in full 2 minutes. So you have to check what's the policy of the organization you are working. So if you don't hear any vowel sounds, that would be your absent vowel sounds. After you do that full 5 minute or 2 minutes vowel sounds assessment, you have to document that, report to the primary care physician. That could be an obstruction, so you have to do right interventions. Alright, so I'm going to be pressing down gently. You have to push down a little bit, because I have to listen to the vowel sounds. I can already listen, but I'm still going to show you how to complete it. Good. Good. So her vowel sounds are within that 5 to 34 bowel sounds per minute. So she has normal bowel sound. It's not hyper or hyperactive. And then what we are going to do, we will be thinking about the next step of that abdominal assessment. Remember, percussion is the next abdominal assessment step that we have to do, but we are not going to do a percussion. The advanced nurse practitioners are doing the percussion. So I'm not even introducing the percussion. Just good to know that that is the third step on your pattern of abdominal assessment. The last one would be palpation. Even with palpation, there are two types of palpation, light palpation and deep palpation. You have to make sure your patient doesn't have any pain. So we'll be asking that in a second. If they have any pain, you will be palpating that part at the last. And we as nurses, since we are not advanced practitioners like nurse practitioners or physicians or gastroenterologists, you will be doing the light palpation, which is like about 1 centimeter down. So what I'm going to do, I'm going to be actually doing a light palpation right now. My hands are cold, so I'm going to make it dry and warm so it will be comfortable for you. So I will be using the same pattern, anti-clockwise. So see how I'm placing my hand on my patient's abdomen? I can place my other hand to support. It's all up to you. Nobody's saying you cannot support your patient's abdomen with the other hand. So any pain? Okay. As I'm pressing down lightly, I'm asking any pain, and also I'm feeling whether the abdomen is rigid. She said already it's non-tender. How is that looks like? It looks distended. You have a large bowel, you have a large abdomen doesn't mean that you have a distended abdomen. You have to just push down and feel. If it's nice and soft, that's a good indication. It's not firm. So you will do that on all 4 quadrants. No pain? Any pain? Any pain?
No.
Good. So during palpation, there are no indications of any pain or any discomfort, and it was soft to touch. So which means your abdominal assessment was actually pretty good. And how about your bowel movement? Do you have a regular bowel movement in a daily basis?
Yes.
So when was your last bowel movement?
Yesterday.
Good. So that's something you always have to understand, because after surgery, their peristalsis is less or motility is less. So the bowel sounds, the bowel activities are less. So high chances of constipation. That's something important for nurses to remember to ask, assess, and document. So other thing with abdominal assessment is this, not for all the patients, but from your physical assessment form, you have to look what other things that goes along with that abdominal assessment or with that gastrointestinal system. Or are they using any kind of drainage system, like they may have an NG tube placed. If they have an NG tube placed, nasogastric tube to drain or decompress the stomach because of whatever is going on with them, if that NG tube is placed on your patient, you have to assess and find out whether it's connected properly, it's functioning properly, what's the color and what's the consistency. You have to look and document those things. You have to even document the amount of that drainage in your NG tube drainage container. And then the other thing, I will be looking at the patient's abdomen again for any kind of ostomies, because sometimes they may have to have an ostomy bag for a temporary or for a long period of time to take their bowel content because of their chronic conditions or maybe cancer. In those cases, there are 2 types of ostomies, ileostomy and colostomy. So think as a nurse, ileostomy, think about where is ileum? It's in your small intestine. So the content or the consistency of that would be more loose or watery. But when it goes to large intestine, that would be your colostomy. It would be more formed. So if you see actually a loose, watery ileostomy bag content, you don't have to worry about it. You just ask your patient or look at your note and see, is it an ileostomy or a colostomy. If it's a colostomy with a loose or diarrhea looking, then you may have to do some interventions. Probably they have diarrhea or they have on special medications. So these are the things you have to memorize under your gastrointestinal assessment. If there are any other findings you may have to pay attention, you probably have to do that, depends on your patient's condition. So the next system is going to be the urinary system, which is actually the genitourinary system. To assess that system, I will be asking you, do you have any issues when you urinate, like burning sensation, increased frequency, going to the bathroom more often than you are usually doing?
No.
No, good. Are you able to go to the bathroom independently?
Yep.
Do you think you are actually urinating enough amount?
Yes.
Good. And have you ever got a chance to actually look the color of your urine? Is it too concentrated or it's kind of a normal color?
Clear.
Okay, clear. And that's something nurses have to pay attention. You have to understand, I need to actually look and identify the color of the urine and the amount of the urine, and if there are anything that I have to pay attention, I have to pay attention, and then I have to document it. And also think about any other urinary diversion devices like urostomy or anything else. If they have it, you have to pay attention and do the proper follow-up. If they have any kind of ostomy, urostomy, ileostomy, or colostomy, and as a nurse, you always have to think to check the skin around the insertion site, wherever the bag is placed, wherever the ostomy is placed. You wanted to make sure the skin is assessed, because that could be an indication of infection. They may have a skin breakdown. It's good to actually find those early and do interventions than waiting for complications. So the next system we are going to be assessing is your integumentary system, or the skin. So in that, I just wanted to actually look at the color of my patient. Is the color appropriate for the race and ethnicity? So I'm looking at Miss Rosemary, and her color is appropriate for her ethnicity, which means her skin is actually healthy. And other thing I will be looking is what's the temperature of my skin. We already checked the temperature of the skin before with cardiac perfusion, making sure that the temperature is actually warm. It's doing good. And then I should also be checking the color and the texture of the skin. Is it jaundiced looking, or it's dry? Those are some indications for you to pay attention, because that could be some of the leading causes for skin breakdown. So as nurses, we are doing this detailed skin assessment, depends on your patient's condition, to prevent future complications. So in your skin assessment, and this is something you have to really memorize, where is their IV access and what kind of IV access. So for example, I'm going to look at your I'm going to look at the forearm for an IV, and I find out she has an IV here, and I will be looking what kind of an IV is that. If the IV is there, is it clean, dry, or intact, which means there is actually a dressing on that IV site, and that's a transparent agadum. So that's dry, that's clean, that's intact, which means there is no signs and symptoms of any infection. So that's something you have to do when you are doing an IV assessment. And you will be asking your patient again, do you have any unintentional wounds or cuts or pressure sore or anything on your skin, as you can share with me?
No.
Good. You have to say those things. And if they have any surgical wounds, you wanted to make sure you actually pay attention to those. Do the wound assessment. How is the wound looks like? How is the surrounding skin looks like? Is there any staples? Is there any sutures? And you have to document and check the condition of those, because it's important to do early interventions if there are problems. And the other thing as nurses we have to do is paying attention to that skin Braden scale. You have that in your physical assessment form. You have to initiate a Braden scale on each shift. So the Braden scale is actually a scale we are looking to see how healthy is their skin, or how good is their skin. If they have higher numbers in their Braden scale, which means their skin is healthy, less chances of having skin breakdown, less chances of having skin problems. If they have lower numbers, that's a problem. You may have to start initiating checking and changing the positions, lotion, and keeping it dry and clean. So you have to initiate interventions as soon as you find that skin Braden scale was low. So that's something you have to always document and pay attention when you are doing your skin assessment. And other thing I wanted to ask you is this, Ms. Rosemary, do you have any history of any kind of arterial, venous, or any kind of vitamin deficiencies?
No.
No. So these can actually impair with the wound healing. So we may have to pay attention to those questions, depends on your patient's condition. And if there are any other findings, you wanted to make sure those are also included in your skin assessment. As I always say, it's all depends on your patient's condition and their medical diagnosis. You may not be asking every single thing I ask, but you need to know those things to put it up here so you can use it as we go, right? So the next system we will be assessing, we already did a part of musculoskeletal assessment during the neuro system, but I will be doing a musculoskeletal assessment a little bit more in detail. So for that, I will be asking you a few questions. You already mentioned you don't have any limitations or restrictions with movement on your upper and lower extremities. Do you have any problems with the balance, like gait when you stand up or when you walk?
No.
Okay, good. So may I ask you to actually stand on the side of the bed? Hold on, before you stand, I have to put your bed down, because I don't want her to fall. I was actually working on my working height. So you always want to make sure your patient is actually to the lowest level before you actually have them get out. And if my patient is able to sit up on the side of the bed without any help, they can do that. So she's sitting on the side of the bed without any problem. Would you be able to stand up? Any dizziness, lightheaded? No? So she's good. And then may I ask you to actually take 5 steps forward and come back. And I'm checking how is her gait. No waffly, she has good gait. You can come back and sit. Thank you. And here, I can cover you up. And here in the musculoskeletal system, yeah, it's just me. I wanted things to be like organized and perfect. So in musculoskeletal system, you will be checking their steady balance. If they have any problems, we have to report, document, and take the initiatives to prevent complications, do the right interventions. Remember about your API, interventions. Depends on what's going on with your patients. And you also have to use that fall assessment checklist that's attached to your physical form. And you have to initiate that fall assessment checklist on your patient's musculoskeletal system to prevent falls, to keep your patient safe. So whenever you initiate that fall assessment checklist, you have to initiate fall preventions if the grade or the number is above 2. So the higher the number, the higher the risk for them to fall. So you have to think as a nurse and initiate the proper interventions and document. And the other thing you have to check as a nurse, is there any other things around the patients that they can trip and fall? Do they have a side table that they can reach? You want to make sure that you keep the side table near to them so they won't reach out for the side table and fall. So those are the things you have to be actually looking under your patient's musculoskeletal system. And also looking under musculoskeletal is this, whether they have any swelling in their joints, because sometimes with aging and with the history of rheumatoid arthritis or osteoarthritis, they may have swelling in their joints, and that could be painful early in the morning, or with gout sometimes, so you have to look at those joint swelling and pain. Any other findings as you think you should be adding depends on your patient's condition. So what we are going to do next is we are going to be doing a psychosocial assessment. In psychosocial assessment, we will be asking questions like, do you feel anxious? If you feel anxious, what would you do? What do you have done in the past? Are you able to manage that without help? Because we want to keep your patient safe. We are not doing the patient teaching just for this moment, for the rest of the life. We have to give that patient education that can help them to deal with issues. And then, as you know, since we already have talked to Rosemary and she was flexible and cooperative, and there is no signs and symptoms of any anxiety or depression, but I'm still going to ask. Now, Ms. Rosemary, what do you think? Are you feel anxious easily? No? Are you sad or depressed? Good. So she doesn't have any of those findings. So she's not agitated. Her behavior is actually appropriate. So that's something you have to actually see. The reason why we are doing it, because if they need help, we can actually give that therapeutic communication and help them to actually achieve their goals, feeling good, being good, those kind of things. And that concludes my physical assessment. As I said, this is the way we have it. You practice it. After you practice, you can actually initiate your own, but do not forget to know everything under that form. Then only you can actually specifically pick and choose what goes with that patient's special needs, how I do a focused assessment. So thank you, and Rosemary, it was really nice to be with you, and your assessment was completely normal.
Thank you.